Welcome back, our fans. Introduction to Surgery and Perioperative Assessment. Surgery is the branch of medicine that deals with the physical manipulation of a bodily structure to diagnose, prevent, or cure diseases. It also refers to performance of such procedures by a surgeon. Why do we need to perform surgery? In 16th century, a French surgeon named Ambroise Paré stated that there were 5 reasons to perform surgery. These are 2. 1. Eliminate that which is unnecessary. 2. Restore that which has been dislocated. 3. Separate that which has been united. 4. Join that which has been divided. 5. Repair the defects of nature. 3 major obstacles in surgery. Up until the Industrial Revolution, surgeons were incapable of overcoming 3 principal obstacles which had plagued the medical profession from its infancy. These obstacles are 1. Pain. 2. Bleeding. 3. Infection. Advances in these fields have transformed surgery from a risky art into a scientific discipline capable of treating many diseases and conditions. History of surgery. The first surgical techniques were developed to treat injuries and traumas. Involved suturing lacerations, amputating limbs, and draining and cauterizing open wounds. This surgery that is evidenced is trepanation, burr holes or craniotomy. Setting bones and splinting, intramedullary fixation with wooden splints is reported in early Spanish texts. Anesthesia using alcohol or opium is one of the oldest surgical techniques reported. Classification. Divisions of surgery, very many. General. Orthopedic. Pediatric. Cardiothoracic and vascular. Plastic or reconstructive. Maxillofacial. Gastroenteric. Neurosurgery. Urology. Types of surgeries. Diagnostic, exploratory, reconstructive, curative, palliative, transplant, elective, urgent, emergency. According to magnitude. Major, medium, minor. Perioperative overview. Introductory information. Perioperative care is a term used to describe the care provided in the total surgical experiences of the patient. It include preoperative phase, begins with the time the decision is made for surgical intervention to the transfer of the patient to the operating room. Intraoperative phase, started from the time the patient is received in the operating room till admitted to recovery room. Postoperative phase, from the time of admission to the recovery room to the follow-up home/clinic evaluation. Types of surgery. Optional, surgery, is scheduled completely at the preference of the patient, for example cosmetic surgery. Elective, the approximate time for surgery is at the convenience of the patient. Failure to have surgery is not catastrophic, for example superficial cyst. Required, the condition requires surgery within a few weeks, for example eye cataract. Urgent surgery, the surgical problem requires attention within 24 to 48 hours. Emergency surgery, situation requires immediate surgical attention without delay. Surgical risk factors. Obesity, danger. Increased difficulty involved in technical aspects of surgery. Suturing become difficult because of fatty tissues, wound dehiscence and evisceration. Increased liability to infection because of lessened resistance. Decreased liability to early ambulation. Poor nutrition danger. Preoperative malnutrition greatly impaired wound healing. Increased liability to infection. Fluid and electrolytes imbalance danger. Dehydration and electrolytes imbalance can have adverse effects in terms of general anesthesia and the anticipated volume loss with surgery. Aging, danger. Potential for injury is greater in the aged. Be aware that the cumulative effect of medication is greater in the older persons. Note the medication as morphine and barbiturates in the usual dosages might causes confusion, disorientation and respiratory depression. Presence of CVD, danger. Many surgical problems may be complicated in the presence of cardiovascular. Presence of diabetes mellitus, danger. Hyperglycemia is potentiated by increased catecholamine and glucocorticoids due to surgical stress. Presence of alcoholism, danger. Additional problem of malnutrition may be present in the presurgical patient with alcoholism. The tolerance to anesthesia may be increased. The presence of liver disorders may present also with alcoholism. Presence of pulmonary and upper respiratory disease danger. Chronic pulmonary illness may contribute to hypoventilation leading to pneumonia and atelectasis. Intraoperative complications. Hypoventilation, after paralysis of respiratory system. Oral trauma due to difficult endotracheal intubation. Hypotension due to preoperative hypovolemia and or as a reaction to anesthesia. Cardiac dysrhythmia, pre-existing CVD, or as a reaction to anesthesia. Hypothermia, exposure to cool operating room environment or loss of thermoregulation capacity as a reaction to anesthesia. Peripheral nerve damage, due to improper positioning. Malignant hyperthermia, rare reaction due to abnormal intracellular accumulation of calcium with resulting hypermetabolic and muscle contraction. Postoperative complications. A postoperative complication is the rule of W's. Wave, wind, water, walk, wound, wonder drugs. Postoperative complications. Shock. Shock is a response of the body to a decrease in the circulating volume of blood, tissue perfusion is impaired, cellular hypoxia and death can result if untreated. Hemorrhage is copious escape of blood from a blood vessels, it may be 1. Primary, at the time of operation. 2. Intermediary, occurs within the first few hours of operation. 3. Secondary, occurs sometime after surgery. Deep vein thrombosis, DVT, occurs in pelvic veins or in deep vein of the lower limbs in postoperative patient. It can occur as a result of injury to intimal layer of the vein wall, or venous stasis. Pulmonary complications. 1. Atelectasis. 2. Aspiration. 3. Pneumonia. Pulmonary embolism is caused by the obstruction of one or more pulmonary arterioles by an embolus originating somewhere in the venous system or in the right side of the heart. Urinary retention. Intestinal obstruction. Hiccups are intermittent spasm of the diaphragm causing the sound, hic, that results from the vibration of closed vocal cords as air rushes suddenly into the lungs. Wound infection. Wound dehiscence, evacuation, commonly occurs between 5th and 8th day of operation when the incision has weakest strength. The highest strength is found between the 1st and 3rd postoperative day. Effective prevention of post-CP must follow a list of goals. Perioperative analgesia. Surgery with less trauma. Avoid nerve damage. Control diabetes mellitus. Early mobilization. Postoperative fever. It occurs in about 40% after major surgery. It resolves without specific treatment in most patients. Causes include within 48 hours, atelectasis. After 2 days, wound infection, anastomatic breakdown, and intra-abdo. Abscesses. After 1W, allergy to drugs, transfusion reactions and pelvic and abdo. Abscesses. A thorough assessment of the patient is necessary. If a likely source is identified, then specimens should be taken wherever possible to identify the causative organism, for example wound swabs for a wound infection. Postoperative hemorrhage. Hemorrhage in the surgical patient can be classified into 3 main categories. Primary bleeding, bleeding that occurs within the intraoperative period. This should be resolved during the operation. Reactive bleeding, occurs within 24 hours of operation. Most cases of reactive hemorrhage are from a ligature that slips or a missed vessel. Secondary bleeding, occurs 7 to 10 days postoperatively. Secondary hemorrhage is often due to erosion of a vessel from a spreading infection. Secondary hemorrhage is most often seen when a heavily contaminated wound is closed primarily. Thanks for watching, support us by likes and subscribes.